to Mario to invite me again to speak about my experience about I'm a hip surgeon, I'm orthopedic surgeon, so I speak to you about my approach to periarticular pain, especially about the hip, and my approach with the ultrasound in the different pain patterns. So what the first part of the talk is about pain mapping, because when I receive the patients in my hip unit, what it shocks more is that most of the patients don't have pain in the hip. They are referred because they got pain usually in the lower back. So I was worried about that, and is that it happens because in Spanish cadera is the iliac crest, and we say the cadera, and when the patient says me duele la cadera, I got pain in my cadera, usually the pain, as you know, in the iliac crest comes from the lower back. So we are not aware about that bias, about that language bias. But if in the English, if you are referred by an English practitioner, the patient or the practitioner would talk about groin pain, and that's more usually referred to the hip joint. So I guess that in English-speaking countries, hip surgeons see more hip pathology than here. So there's a bias, there's a cognitive bias in the communication of pain, because common language is not precise enough to express anatomical or topographic information, and the treating professional makes his own assumptions about the origin of the pain and tags the pain. Say pain from the hip, and since refers to a specialist, and you lose that information in the way. So when we started to travel around the world in the 14th century, we were aware that we needed topographic informations and we needed maps. But nowadays, what kind of maps are we using to localize pain? This is the map of my pain unit, and it hasn't changed a lot. And you see that it's very, it's a very simple image with the dermatomes, and that would be meralgia paresthetica. And you see, well, what kind of information it gives? A little, very little. And in questionnaires like the McGill pain questionnaires, you've got many words to describe the pain, but the map pain is still very simple. It's just to the front and back image of the body. You've got APPs like this tracker, that is a very good one. You've got many descriptors of the pain, but you also see that the map is the same. It's very simple. There are other APPs with and this is more useful because it describes the different patterns around the hip, and I use it. And I've got this APP and I use it, but also you see that the pattern is a flat front, back, or lateral view. And what the patient does in this case is he makes his own pain map. This is and you see how they are aware that the description of the pain is surely related to the origin of the pain. And in this case, you see how the patients describe three possible origins of the pain: tipus dolor, sacral, ischiotibial, and ingle, groin. And the patient is aware that the pain pattern is related to the origin. And in this case, the patient is also aware that the doctor doesn't pay attention, and that the doctor just writes a pain in the hip. No, it's not pain in the hip. I got three different pains. And you see also that when there's a complex pain, I think that you've seen this, that the patient comes in this case with what tries to be a right foot, that's the knee, that's the ankle, and he describes dolor frecuente, common pain, very, se hincha y doloroso, it swells and it's painful, that's the toe, bastantes veces, quite often. So the patients try to make his own pain map. And what's in the literature? Not much. It started 60 years ago with pain charts around the back. Around the back, well, I go quickly along because there's not so much literature and there's nothing special. So, well, in this case, in back pain, you've got this very old publication. There's a recent one, Uppsala from Sweden in 17. And it says that the pain drawing can predict the outcome of surgical treatment of degenerative this disease, and uses a very simple map. And it says that if you got pain along the arm, it's a good predictor of the outcome of the surgery. But you see that it's not as much. What is in periarticular pain? There's some publications in knee pain, and there are only these 3, and in these publications, well, just going quickly, they say that it's reliable. It's reliable. It means that the patients can reproduce the pain pattern, can draw the pain patterns at that an observer can also draw the pain patterns. That's reliable with these very simple patterns, and you can, and with this photographic knee pain map that is more, is more precise anatomically, you can also have some correlation with the pain origin. And there are some applications where you can draw the pain. For example, this one, and where there's a correlation between the surface of the pain that you draw and the origin and the result. And this one from this year, from a pain unit in Hanover, it compares. You see that is only the front and back. It's plain. It's a plain, and it compares the drawing pattern between the doctor and the patient, and it compares the correlations, and there's some correlation, and they are starting to work with these pain patterns, but in this just with the flat surface. Well, and there's nothing more. In the shoulder, there's a group. There are 2 publications by the group of Bayam, where he finds that there's correlation between the pain patterns and four pathologies: impingement syndrome, rotator cuff tear, glenohumeral joint arthritis, and instability. And with pain descriptors and pain drawing, this group find correlation between the origins. So that is a first step of finding correlation between pain patterns and origin of pain, and not losing that information, as I told you. When I go quickly, and conclusion: shoulder maps may be more useful. Clinically as an adjunct in initial assessment. This is the conclusion of the study. Sorry. So what's my personal approach? So I made my own pain patterns. I work with hips, so I make you all know the orthogonal projection. So I use, that pain, it's usually referred to quadrants: anterior, medial, lateral, posterior. In the case of the hip, the medial quadrant the groin is not useful, so I use 3 quadrants. It makes the squares are common, so it's only 21 squares, and most of the pain in the hip is referred to these quadrants. So I try not to lose the information where the pain comes from. And you can use it for the knee also, but now with the new technologies, there is software, 3D software, open source software, and we are working with a group of vision or computer vision, artificial intelligence of the university where I work, and we are trying to use 3D models with topological segmentation. So we are going one step, and well, this would be, well, what? Yes. Well, it's. Wait. Es que no, para darle. Es que es aquí en teoría. No, para ver. So you can. This is a 3D model. You can manipulate the model. You can manipulate the model, and you can draw in any part of the body. Well, with color the paint pattern, and you can save it to your computer, to your information system. So, and it's a very complex, and we are working in the university, but we are working with a 3D model, and that's quite new and very complex. So my stepwise, now I go to my stepwise approach of the hip pain. That's what I work usually. So I do the pain mapping. I don't lose the information of the original pain because it may change. And I don't use growing pain, or I use lateral pain, growing pain, but I try to draw the pain and to keep track of the map. Afterwards I do directed exploration. I usually do a ultrasound if, well, in case of doubt. I have a first diagnostic impressions. We can use also the ultrasound to do ultra-guided procedures. And in the case of the hip is very useful because the anatomy is very complex. There are many structures involved in the pain, and they're very difficult to palpate. So the ultrasound image and the ultrasound guided procedures in the hip are very extremely useful to know where you are injected, and I'll explain you a little of the causes, and practically everything is reachable with a needle. So in this way I can have a more precise diagnosis impression, and afterwards we have to use an outcome measurement to close the circle and to know if that pain mapping is related really with the diagnosis, and if we've done it's been useful or not. Well, in the hip there are three major pain patterns: anterior, lateral, and posterior. The anterior pain pattern is the one that is more related to hip pathology. The lateral pain pattern, that is the most common, is related to greater trochanteric pain syndrome, and the posterior pain pattern is the most difficult to define. And it's now there's a diagnosis that is called deep gluteal syndrome that includes, well, I'll explain you a little about what's going on about that, but it's still a very agree scale field. But anterior pain, it's very commonly and the central square, and the midline is mostly related to hip pathology, and in the young patient mostly related to what maybe you've heard about, femoroacetabular impingement. You got also in the same line the psoas, and in the more laterally on the anterior inferior iliac spine, you've got the rest of femoris. You've got also the meralgia paresthetica in the upper quadrants, and in the medial quadrants you've got the dynamic osteopathy of the pelvis. Well, then what's the nerve supply of the hip? The nerve supply of the hip is quite complex. You've got four sources of innervations. In the anterior half, you've got the origin from femoral obturator, and in the posterior half, you've got from the superior gluteal nerves, the nerve of the quadratus femoris, and part of the sciatic nerve. And there's an anatomical law that is called Hilton's law, very old one, that it says that the nerves that innervate a joint also innervate the muscle that moves it, and the skin that covers the insertion of those muscles. Well, I don't know if it's precise for every joint, but it gives an insight in the pain pattern around a joint. I mean, if you got a joint, a pain in the knee, well, you may have also pain related to the muscles and the nerves. And well, this is the Hilton that you know. Well, there are studies about innervation of the hip, not many, and you see that most of the innervation is in the anterior half of the joint. And well, that would be femoral and obturator. You know that you can do radio frequency of the hip joint. What's the femoroacetabular impingement? Just I'll go quickly. It's, well, I'll try. I like to. Okay. No. Okay, yo lo tengo en el archivo. Okay. Well, the idea, the femoroacetabular. I'll explain you. The femoroacetabular impingement is where there's a bump. You know, there's the femoral head is not a sphere. There's a bump over here in the anterior femoral head junction, and inflection. That bumps hits the labrum. The labrum is richly innervated. It's the most innervated structure in the hip, and that bumps eventually breaks that labrum and the cartilage underneath, and that produces the pain in the groin and in the anterior half of the hip. That would become impingement, and well, that's the labrum, and the labrum in the femoroacetabular impingement is usually torn in the upper quadrants, usually anterior superior. That's why the pain is more related in the hip, in the femoroacetabular impingement, to the anterior hip, and inflection, the maneuver. That's a maneuver, and the maneuver I'll explain you, because it's very easy to do. It's very easy to do, and it's a very common cause of pain. So the pain from the hip is usually an inguinal pain, but it may also have some component posterior, because you see that the capsule has got also innervation from the posterior branches. So we call C pain, because the patient holds the hip like this. You may have mechanical symptoms if the labrum is unstable, and is related to maximal flexion and flexion with some internal rotation, because that's where the bump get impinged. Again, the labrum get impinged between the bump and the pelvis. So this is the impingement test. It's very easy to, and you have to go to maximal flexion, some adduction, and internal rotation. That is usually limited. You know, when you got coxarthrosis, the first sign is the limitation of the internal rotation. That's impingement test, and that's the most common cause of anterior pain. Just over the hip, you've got the psoas. The psoas, I compare the psoas to the biceps, the long head of the biceps, because it's also in the anterior surface of the joint, and it's very painful. In the psoas, you've got two components. This is the iliac muscle, and this is the psoas muscle. Over the hip, you've got the tendon of the psoas. And the tendon, it usually got two or three components, and that tendon can snap over the eminence, the iliopectineal eminence, or it can grab around the iliac muscle, and that's the causes of the snapping hip. There are two causes of snapping: the intraarticular snapping that is produced by the psoas or an unstable labrum also, and the lateral or extraarticular snapping that I'll go later when I speak about the greater trunk. So the psoas is a possible cause of pain in the anterior hip. As you see here, this is the tendon with its three components, and that's the bursa, and this is the hip joint. So you see that is very close to it, and it's especially important after a hip surgery. When you do hip surgery, you open the capsule, for example, in an arthroplasty or in a hip arthroscopy, and when you open the capsule, the psoas get in touch with the hip directly. So when there's a painful hip after a hip procedure, I always scope the psoas. I try to see, I'll see you, if there's a cap, if there's a hip cap, it may get, the psoas can wrap along the cap, and it may be a very common cause of pain. This is a hip prosthesis, and you see, if the cap is protruding anteriorly, it comes directly in touch with the psoas. So it's always painful. That's a very common cause of pain after an arthroplasty. Well, more laterally, you've got the insertion of the rectus femoris. It's very, and you can scope it very easily with the ultrasound. It's, as you know, more related to overuse pathology in our country, soccer players, and you may have also, and it's not uncommon, the avulsions in children, avulsions of the anterior iliac spine. And well, the last, you all know the paresthetic neuralgia. That the femorocutaneous, it's easily, you can find it easily under the ligament, under the inguinal ligament, and you can follow it with the ultrasound, and you can it's easy to find and easy to block. And what are the usual ultrasound injections in the anterior hip? And very easy to do, and that's what we'll do. The intra-articular is very easy with ultrasound. I do it. It's very difficult to do it blindly, but with the ultrasound, it's very, very simple. If there's a labral detachment, you may have a paralabral cyst, and these paralabral cysts are like the parameniscus cyst, and may impinge on the psoas, and these paralabral cysts are very painful. And you can inject them, and you can aspirate the paralabral cyst with the ultrasound. You can inject the iliopsoas bursa. You can treat the rectus femoris insertion. Well, on the medial side, it's very common the lesion of the adductor longus. Well, you all know all the nerve blocks that you can do in this area. Well, I go quickly because I'll explain it on the cadaver. That's the femoral head. That's a paralabral cyst, and that's the psoas. That's over. So you can inject directly to the paralabral cyst. Well, I'll go later, and well, all the blocks that you know. Well, the lateral pain pattern is the most common cause of pain in the hip, and it's also a very suitable place to use the ultrasound. And here we got also a snapping syndrome. That is called the extraarticular snapping syndrome. I'll go later. So that greater trochanteric pain syndrome is the most frequent pain in the hip region, and as you all know, it's very easy to diagnose because you find tenderness in the trochanteric region, and what I ask the patient always is if he's able to sleep on that side. If the patient says that he's not able to sleep on that side, I'm 100% sure that he may have some pain from that region, and it's not usual to find frank bursitis on the ultrasound. So even if you do ultrasound, if you don't find bursitis, don't worry, because it's not usual to find liquid inside the bursas, but you can inject it. The pain is if you palpate the troch and he can sleep on that side, it probably would come from that side. Well, it's very important to know the anatomy of the greater troch. I'll stop here because it's very easy to inject the bursa of the greater troch, but to inject, there are three bursas. Every tendon, every gluteal tendon, you got major, medius, and minor, they got its own bursa. So you got four facets: anterior, posterior, lateral, and posterior superior, and three bursas. The posterior under the gluteus maximus, the superior under the gluteus medius, and the anterior under the gluteus minimus. And you got two sides of insertion. This is the gluteus medius, that is an oblique line, and its bursa is here, and the gluteus minimus is in the anterior. So it's complex to do a diagnosis with the ultrasound, but at least if you know where the three bursas are, if you see the trough, the greater trough, you can direct the needle to these sites. Of ruptures, but to find the bursa with the ultrasound or where they are, it's easy. So you got that gluteus medius with that oblique insertion. The gluteus minor is in the anterior side. Well, just palpating is very easy to find the tender point. And what's the external snapping? When the patient lies on the lateral side and you feel a snap of the iliotibial band, that's the most common cause of snapping in the hip, and that's called external snapping, and it's very easy to check with the ultrasound. With the ultrasound, you see where the iliotibial band the iliotibial tract jumps over the greater trunk. So here it's very easy to do the infiltrations and to check if there's a Morella Valley effusions. Is very easy to withdraw the liquid, to analyze it, and just the end would be the posterior pain pattern, and this is much more complex. When a patient comes with a posterior pain pattern and only in the posterior side, I'm not very comfortable, because I think that doesn't come from the hip. It may come from the low back pain. That is a very common pain pattern of refer pain from facet joint pain. You got also the cluneal nerve. You know that there the superior, medial, and inferior cluneal nerve that are not very well known, and they've got that distribution in the posterior buttock. You can eventually see the superior cluneal nerve, but not the posterior, the inferior, that it's the one most related to this pain. You got also sacroiliac pain, and now instead of piriformis, we speak about deep gluteal syndrome, but because the sciatic nerve can get impinged in not just under the piriformis, but all along it's all along the posterior side of the buttock. You can also have some origin of the hip pain. You've got now a recent descriptions of cause of pain is ischiofemoral impingement between the ischium and the lesser trunk, or the posterior part of the greater trunk, and you got also here the hamstring tendonitis. So it's a very complex region of origin of pain. Well, you all know the piriformis syndrome, but now we speak about what is deep gluteal syndrome. The sciatic nerve can get entrapped not just by the piriformis, but by fibrous bands. And there's a publication of Spanish authors, of hip surgeon and radiologists, that they've described these different patterns of nerve entrapment. And hamstring enthesopathy, that's a very common cause that you all know. You can check the insertion with the ultrasound, and you can here do a piriformis block. You can treat the hamstrings, and you can now we are starting to do hydrodissection of the sciatic nerve to deep gluteal syndrome, not just block the piriformis, but dissect with hydrodissection, and I think that's appealing for me, to try to hydrodissect instead of doing open surgery. So that's what you can do. So the take-home message is the patient comes from the pain, and the pain is the main reason for consultation in medicine in general, and we are losing that information. So we have to keep in mind and you have to register the pain pattern, because it's got a diagnostic specificity, and the patient refers that to an anatomical superficial region. So we have to record that anatomical superficial region, and we have to use measurement tools to validate our procedures. That's it. So I hope that you don't get lost in translation. Sorry for that.
Any questions? go to www.ultradissection.com or info@ultradissection.com.